I think we can start. Dr. Alvaro Campero is the moderator. This is the management of trigeminal neuralgia, a difficult topic. Yes, it is time for starting, Dr. Alvaro.
Okay, thank you.
Remember, John is joining.
Sorry?
Mehmet,
Yes,
John is joining.
who is joining?
Okay, we will see when he joins.
Okay, let's go to start. Okay, hello everyone. Thank you for being here. We will start the Zoom about the trigeminal neuralgia with four topics: anatomy of the trigeminal nerve, then the surgery with the microscope, then the surgery with the endoscope, and finally the percutaneous treatment of trigeminal neuralgia. So the first speaker is Dr. Matías Baldoncini from Argentina. So please, Matías, go ahead.
Good morning to everybody. Good morning. It's a pleasure to see so many friends from around the world. And thanks again for the invitation to the WFNS. It's a huge pleasure for me to speak about trigeminal neuralgia, especially being there Professor Alvaro Campero, because I learned every single detail what I know about trigeminal nerve surgery from him, and that's why it's a huge pleasure to me. We will try to observe the different details of the anatomy of the trigeminal nerve, especially focus in the topic that we are trying to emphasize nowadays. That is the treatment for trigeminal neuralgia. And we know that not only for trigeminal neuralgia it's important to learn the anatomy of the trigeminal nerve. As we can see, the anatomy of the trigeminal nerve is very important, and it's a really complex anatomical structure, because it goes from the posterior fossa to the middle fossa, and one of the branches enters to the orbit, and the anatomy is really complex. And as everybody knows, the trigeminal nerve is a nerve who provides the sensibility, the sense of touch and pain of our face. And it's divided in the three branches: B1 or ophthalmic branch, B2 or maxillary branch, and the B3 mandibulary branch, or the inferior branch, where the inferior branch, it's in near contact with the motor root of the trigeminal nerve, very important for the movement of the masseterian muscle. The trigeminal nerve is an important nerve that the origin of this nerve is located in the anterolateral surface of the pons. And it's a very important landmark, because from medial to the origin of the entry root, or entry zone of the roots of the trigeminal nerve, from medially, we will find the pons, and laterally the middle cerebellar peduncle. That's why it's a very important landmark. But it's an important nerve. With the second nerve, or ophthalmic nerves, there are the more important nerves in order to the quantity of fibers that runs inside of the nerve. And it's a very important anatomical landmark, not only for the separation between the pons and the middle cerebellar peduncle, because there are an important safe entry zone to the pons. That's the name of this zone is the peritrigeminal nerve, because the nerves course through the fibers, through the transversal fibers of the pons in order to reach the nucleus of the trigeminal nerve. That is a long, sensitive nucleus that is located inside of the not only the pons, the mesencephalon, the mesencephalon, and the medulla too. And if we observe this sagittal section of the posterior fossa, and we try to select an axial section crossing in the superior third of the pons where the nerve is located, we can observe this interesting anatomy of the nerve. This is an axial section of a human head, and we can observe the following anatomical details. The nerve cross from posterior to anteriorly, from medially to laterally, and depending on each patient, but mainly time it goes from inferiorly to superiorly in order to reach the Gasserian ganglion located in the Meckel's caves, in the Meckel cave, where it's located in the middle fossa. Okay, and the nerve in the posterior, the trigeminal nerve in the posterior fossa can be separated in three segments. The segment where it's located close to the pons, where it's the entry zone of the trigeminal nerve. And this point is very important for the topic of today, because mainly times the trigeminal neuralgia caused by neurovascular compression is related to the artery compression in this anatomical point. That's why it's very important to reach this zone if we use the microscope or the endoscope in order to observe if the nerve is compressed or displaced by some artery or vein at this point. The second part is the cisternal segment of the nerve, and the third part is the part that is entering to the Meckel's cave that we can observe there, like a foramen of the dura mater, where the nerve enters and ends at the Gasserian ganglion. That's very important. In this anatomical specimen, we can observe another important anatomical landmark, that is the suprameatal tubercle. Okay, this anatomical structure sometimes it's located in the middle of our approach. If we select to operate this nerve using an endoscopic or microscopic approach, so, mainly time we select the retrosigmoid approach. And in some cases, we can observe a huge suprameatal tubercle, and it's difficult to reach, especially the distal portion of the nerve. That's why especially young neurosurgeons that start operating this kind of pathologies need to keep in mind that if we are not able to reach this part of the nerve, sometimes it's important to remove the suprameatal tubercle. And of course, the neurovascular complex that's in close relation with the trigeminal nerve is the superior neurovascular complex. Sometimes the nerve it's in close contact with the superior cerebellar artery in the superior surface, and in an inferior surface can be reached by the anterior inferior cerebellar artery or the AICA, okay? And sometimes, like in this specimen, when we can observe a dolichoectasic basilar artery or vertebral artery, can be in close contact with the trigeminal nerve and could be related with trigeminal neuralgia, okay? And not so frequently, the nerve can be compressed by veins, and this could be the reason why our patients suffer trigeminal neuralgia in neurovascular in the neurovascular complex of the superior complex of the posterior fossa. This is a superior view of an skull base where we can observe here in the apex of the petrous bone where the cavum of Meckel is located. Okay, and in the cavum of Meckel, of course, we will observe the Gasserian ganglion, and in the Gasserian ganglion, the nerves separated in the three distal branches of the nerve: the ophthalmic branch that enters in the middle part of the superior orbital fissure, the maxillar branch where enters in the foramen rotundum, and in the foramen ovale, we will observe the inferior or maxillar branch of the nerve. Of course, in order to dissect this part of the nerve that is located in the middle fossa, it's mandatory to perform a middle fossa peeling, okay? If we need to operate, for example, the topic of this webinar is neurovascular decompression, but sometimes the nerve can be in close relation with trigeminal schwannomas, for example, and sometimes we need to perform a middle fossa peeling in order to expose the B2 and B3 branches, as we can observe in this specimen dissection. And this is the B1. B1 going through to the superior orbital fissure, B2 foramen rotundum, and B3 to the foramen ovale in close relation with the intracranial course of the middle meningeal artery, which is an important element we need to coagulate if we are approaching the nerve in this part of the Gasserian ganglion or the B1, B2, or B3 branches, okay? As I said some minutes ago, in the posterior fossa, is very interesting because we have the rule of three. The brainstem have three segments. The cerebellum will have three surfaces: tentorial, suboccipital, and petrosal, and we have three neurovascular relationship or complex, and the trigeminal nerve is in close contact with the superior neurovascular complex, okay? And mainly times the nerve, when we have to operate the patient with classical trigeminal neuralgia caused by the vascular compression, mainly time the problem is because the nerve occurs very close to the superior cerebellar artery that is here. But sometimes, as I told you, sometimes it can be in close contact with the inferior cerebellar artery, and less frequently with the vertebral or basilar dolichothoracic artery, or some venous that drains frequently to the superior petrosal sinus can cause in close contact with the nerve and can produce trigeminal neuralgia as well. As we can observe in this vision of the posterior, this is a posterior view of the anterior part of the posterior fossa. This is the sixth cranial nerve entering to the Dorellos canal, and this is the nerve, trigeminal nerve, entering to the dura mater in order to reach the trigeminal, the Gasserian ganglion. That's here we can observe the 7 and 8 cranial nerve and the contact of these duplicated superior cerebellar arteries to the nerve. And here we can observe this beautiful anatomical specimen that represents the real situation that we observe in our surgeries when we need to decompress the nerve to superior cerebellar arteries displacing downwards the trigeminal nerve. That's really frequent. And we don't need to forget sometimes that this vein of the petrosal veins or vein of Dandy, sometimes we need to dissect this vein in order to reach the trigeminal nerve, or sometimes this vein, the medial location of the vein, these postmeatal veins, can be in close contact with the trigeminal nerve. Something that is really, really important, especially for young neurosurgeon who operates trigeminal nerve neurovascular decompression or trigeminal nerve schwannomas or tumors located in the cerebellopontine angle, is to preserve as many as we can this vein in order to prevent the venous infarct of the brainstem or the cerebellum. Here we can observe a beautiful endoscopical image trying to observe this suprameatal tuberculate, this very huge suprameatal tuberculate that if I use only the microscopic view, it's very difficult to observe the point where the nerve enters to the dura mater and to the cavum of Meckel. Here, this small branch of the nerve is the motor root of the nerve. And as I told you, the veins need to be preserved because sometimes these veins drains the venous drainage of the brainstem, especially to the pons or the mesencephalon. Here we can observe how the nerves is all covered by arachnoid. Sometimes when we operate the patient that are suffering trigeminal neuralgia, we can observe a very dense, a very strong arachnoid surrounding the trigeminal nerve in our surgeries. Of course, and this will be an interesting topic the next lectures, of course, from Mauro and the colleagues. The position that we use to operate this patient could be in semi-sitting position or retrosigmoid approach using a park bench or only a regular dorsolateral position of our patient. We prefer to use for this kind of surgery to approaching the trigeminal nerve in the posterior fossa, the semi-sitting position, because we feel a little bit comfortable during these surgeries. Of course, sometimes takes more time, sometimes take less time, but at least we need 15 or 40 minutes in order to position our patient in semi-sitting position for an appropriate semi-sitting position of our patient for retrosigmoid approach. That's very important if we use semi-sitting position to elevate the legs up in an upper level to the heart of our patients. We try to not produce venous compress in the neck, venous compression of the neck, sorry, and our position is ready for perform our retrosigmoid approach. We select to mark with this element the asterion, that is an important landmark, and we start our approach to the retrosigmoid approach. And our philosophy that we try to promote, to share with our colleagues, especially for young neurosurgeons or young residents, and we agree with Professor Abuzer, Güngör, with his philosophy too, trying to go from the laboratory to the operative room, because the anatomy that we can learn in the laboratory, for example, in this double compression of the trigeminal nerve, we can be able to reproduce it in our patients if we train in the laboratory first from the laboratory and then to the operating room, trying to give the best for our patients. Again, thank you very much to everyone, especially for the committee of the WFNS for the invitation. And in this photo, we can observe one of my academical house, that this is the Faculty of Medicine of the University of Buenos Aires, where I live, and everybody are welcome to come here when you visit Argentina. Thanks again for the invitation.